wanted to introduce someone very special who helped me maintain my sanity over the last couple of weeks. That's Dr. Florian Kuchenbauer.
So, good morning. If anybody needs a translation, I'm fluent in German. And just a couple of points after these lovely presentations from a physician's point of view. So when I was still a little bit younger and I was still able to go to parties, and people usually talk about their jobs and what they do, and somebody asks you, so what do you do? And I was a little bit naive at that point. This was early in my career when I said, like, oh, I'm a physician. And they're like, oh, what kind of physician? And I guess when you talk to females at that point, and then you're a little bit tipsy, you're like, oh, I like cancer. And then usually the answer you get is like, oh, isn't this so sad? And then the second reaction is like, I don't want to come to you. And this is not a good reaction. So, but you know, when you become older and you hear these stories of Libby and Lisa and how this community kind of thrives and how people support each other, that's exactly why we do this. And it's not sad. These are good stories. These are things why we work, why we come every day to work, why we talk to you, share sometimes frustrations. And I can understand that it's sometimes difficult from a patient's point of view to relate to a physician, because we always try to keep a little bit of a distance, to keep emotions out of the game, but at the same time give emotions back. So these are things that are really important to us. And this is the reason why we should take this conference as an opportunity to talk. And that's why we call this conference Time for a Conversation, because it's not about just presenting data and saying, hey, this works great, this is good, but it's about like sharing experiences. And this is important from both sides of the end, right? From a patient's perspective as well as from a physician's perspective. So please take advantage of this. And the next part is about research, giving you introducing diseases and also talking about what is new, what has been doing, which parts we want to do research. And we do a lot of research here in Vancouver. And the first person I would like to introduce is Dr. Kevin Hay. He's like the CAR T-cell expert here in Vancouver. And it's really an honor to introduce him and to hear him speak. So give him a warm welcome. And I hope you enjoy the next 90 minutes. Thank you very much.
First of all, thank you very much for inviting me here to speak to all of you. I think this is just such an important time to have together and just really meet and have a conversation together. Unfortunately, I stand in the spot of having come after some very good speakers, and I feel like anything I have to say in after that is very, very minimal. So thank you very much for both of you in your presentations. That was very, very poignant, and that's really why we do what we do, is to hear those stories. So thank you very much, both of you, for talking about that, and for the important advocacy you do for helping patients through this, because it is definitely something that is that really strikes right to the core of who you are and what it means to live. So thank you very much for that. So that being said, I asked to go first, unfortunately, because right after this, I have to run back to our transplant ward because I'm actually working this weekend. So just bear with me, but I'm happy to kind of continue the conversation later if at all possible in some way. So I'm supposed to talk to you here about a new therapy that's come along called CAR T-cell therapy, and that is really making a huge shift in how we're treating some types of leukemia and lymphomas. So what is CAR T-cell therapy and why CAR T-cell therapy? So we do know that T cells are a part of the immune system that does recognize abnormal cells in the body. So this is typically like early cancer or virus infected cells. So the reason why there's a lot of people who don't end up getting cancer is because those T cells are working a way to actually find a way to kill off these cancer cells before they become a complete cancer. So usually, once a cancer has become a cancer, it's found some way to evade this very important cell in our bodies. So A good example of this is in a type of cancer called diffuse large B-cell lymphoma. Basically the normal mechanism by which a T cell recognizes a tumor, the tumor cell, those diffuse large B-cell lymphoma cells, they find a way to hide from those T cells in about 60 to 70% of cases. So what we do with this new therapy called chimeric antigen receptor CAR T cell therapy is we make a new sort of receptor to put into the T cell. So we genetically engineer a new T cell from that patient's own T cells. And then now we're able to have this new therapy that is able to recognize some sort of a target on that tumor cell and kill off the cancer cell. So how do we make this? Well, basically, we first of all have somebody who's in need of this therapy. So some sort of a patient with leukemia or lymphoma. We then first of all take out those T cells from the patient's own body and then introduce in this new molecule called the CAR that now goes onto the surface of that T cell. And then we grow and expand them outside the body in the lab. And then we put them back into a patient on, usually typically after about 2 to 3 weeks of this. We still need to use some sort of chemotherapy. It's really necessary for these CAR T cells to work really properly. So it's not a chemotherapy-free approach, but it is. It's definitely relying on the T cells themselves and not necessarily completely on the chemotherapy to have its effect. And then what happens afterwards is that these cells grow and expand inside the body once they're put back into the patient's body over a period of about 2 to 4 weeks, and then they subsequently decline and then enter into a level of low-level persistence, hopefully especially in those cases of leukemia, where they're now able to provide some sort of a surveillance mechanism to prevent relapses of the leukemia. So the first aspect of this, if you notice, is to really have a good target, something to really attack. And so this is a lot of the difficulty in CAR T cell therapy, and this is why you're maybe not hearing it about a whole bunch of different cancers right away. This is one of those reasons. Because you need something that's first of all present on all the cancer cells, because if you only kill off half the cancer cells, that's not going to do it, right? And it also needs to be absent on non-cancer cells, because you don't want to destroy the rest of your body with this therapy, or absence of those normal cells you can tolerate and that's manageable. So it just so happens that, although B cells are important, they're not really quite essential for our life. We can live without our B cells in some ways. Now, again, that comes back to what do you mean by live without them and, quality of life. And we are going to be looking into some of those things about long-term outcomes in patients who don't have B cells for a long time. And that's something very important that I think we need to take into consideration with further research. But at least in the short term, so far as we've seen for, 3 to 5 years or so, it seems like patients are doing quite well without these B cells. And so as I said, it knocks out all your B cells, but it also can knock out these types of acute lymphoblastic leukemias that are B cell type, as well as a lot of B cell lymphomas. So CD19 is a very good target. We also had an urgent need for better therapies. Now, we as physicians always show these types of graphs that basically are showing how patients are surviving after having a diagnosis. And, the part that's really hits home to me is that each one of these drops off this curve is another person, right? And this is really, really hits home to me that these aren't just numbers. These are people, every single one of these. And so by the time you get out to about 6 months, half of these people have died of their leukemia or of their lymphoma. So we had an urgent need to have a better therapy at this stage. So these are just a few different trials that were run down in the US. And we were able to, with this, demonstrate that in these cases where patients basically had no other treatment options, that 50% of patients would have been dead within 6 months or less. We're able to clear out the disease in about 75 to 85% of these patients who had ALL. And in diffuse large B-cell lymphoma, these are two major trials where we demonstrated that now, historically, we were only able to completely clear out the disease in about 7% of these patients. Now we got this up towards 50% with this therapy. And most of those patients who had a complete response still remain cancer-free at about 3 years time period on average. So some a bit longer, some a bit shorter. So this has been a tremendous change in how we treat patients who have gone through at least 2 or more lines of therapy to try to treat their B-cell cancers. But there's some realities that go along with this new therapy as well, right? With every new thing we try out, like for example, in CML, we said, look, great, we have all these wonderful drugs, just use all these different drugs, right? But there's real side effects associated with those drugs, right? So we can't disregard what's happening. So what's the reality of CAR T-cell therapy? What are the side effects? What are the chances of the leukemia or lymphoma coming back? And why don't we have this for other cancers yet? What can we do to expand it? So this is some of what my research kind of focuses on. So the side effects of this, first of all, it's that chemotherapy-related side effects because you can't get away from the chemotherapy. Now, I think I don't need to talk too much to this group about what all those chemotherapy-related side effects are, right? I mentioned this thing called B-cell depletion, where those normal B cells are lost from the body in the process. This does, as I said, appear to be well tolerated in patients with no long-term ill effects. It can potentially make some patients more prone to certain infections, but if they get those certain infections, what we can do is we can give them immunoglobulins, so basically antibodies from other people that other people have donated. There are also some very specific toxicities to, though, this new type of therapy. One is called the cytokine release syndrome, or CRS, and the other is called ICANS, because, you know, we're doctors, so we have to make an acronym for everything, right? So this means immune effector cell associated neurotoxicity syndrome. And immune effector cell just basically means a T cell, for example. That's an immune effector cell, but they made it a broader category because there's also a bunch of other cells that we're trying out this kind of approach with. So they wanted to have it a little bit broader. So first of all, what is that CRS thing? Well, it's an overactivation of the immune system because we're putting in now these T cells that are primed to kill. They're primed to kill the cancer, and usually into people who have a lot of cancer burden in their body. And so you get the sudden death of all these cancer cells, but in the interim, the immune system gets highly activated by this whole approach. And so basically, it's called CRS because it releases all these immune cell molecules called cytokines into the blood, and this is part of what leads to some of the symptoms. So cytokines are some of the things that help cause fever in you. So like, you know, when your immune system is reacting to a flu and you get a fever, part of that is driven by the immune response, right? It's not the flu itself, but it's the body's response against the flu to say, let's make a fever, right? And so in CRS, the initial symptoms are very much like a flu. You get a high fever, you get chills all over, and just feeling all those shakes in your body, right? Unfortunately, what can happen in some patients is they progress from that to actually having a low blood pressure, where they need to really get IV fluids to keep their blood pressure supported. And then subsequently, they can even get sicker and end up in an ICU to need some blood pressure support. So this can also happen in, as we know, people who have the flu, right? There's young people, there's old people, there's a lot of people who have the flu who can suddenly end up in the ICU because of the flu itself. So that's why I use the flu to kind of describe the full spectrum of what can happen. So this low level happens in the majority of people who get this therapy, but this kind of progressing all the way to ending up in the ICU with failure of your organs happens in a very small percentage of patients. Probably there's a difference in this rate of CRS depending upon what CAR T-cell product is used. There's a bunch of different CAR T-cell products out there right now, but it's really difficult to compare directly. So I said it occurs close to 70% of the time and more severe in about probably actually closer to 7% or less now that we know how to manage this better. So what is that ICANS thing, that neurotoxicity? It's basically almost any symptom affecting the brain and the nerves. It's really frustrating, especially for neurologists, actually, because they like to have very clearly defined sort of syndromes and everything that looks very perfectly and logical in their head. And this actually doesn't follow a lot of logical patterns. And we're still really trying to understand what exactly causes it. But some of the common early findings that we found is that patients will initially get a tremor, some difficulty writing, and trouble speaking, trouble expressing themselves. And so we actually monitor patients on this therapy fairly regularly for these findings, so we can see if they're developing any of this ICANS thing. It's possibly part of the CRS, or at least associated with it. It occurs in less patients and, more severe, not necessarily ICU kind of needing therapy, but more severe and closer to about 10%, I would say now. And this can actually be very scary for patients' families because they see, their loved one basically sometimes just suddenly go blank and not be responsive. And it's extremely frightening for, the physicians, for the nurses, for the patients, families, etc. But the big take-home message from this is that really it's reversible in the vast, vast majority of cases. Over 95% of cases is completely reversible. And anytime it's reversed, it doesn't seem to be associated with any long-term side effects to the brain that we've seen so far. Now, that being said, this is something that also requires further research, right? So the timing of the side effects typically happens usually within the first 5 to 10 days after receiving this therapy. So that gives us a little bit of a window of opportunity here in order to try to make new interventions to try to either reduce how severe these toxicities are or to get rid of them entirely. So there's a lot of active research going on right now in really reducing these toxicities and making this a much more tolerable therapy. So we do have some good things to treat this CRS with. The goal is to really shut down all those extra cytokines. So we use this antibody that actually blocks one of the main cytokines that causes the symptoms. It's called interleukin-6. So the antibody is called tocilizumab. And we also use steroids. Like, it seems like everything in medicine to suppress the immune system, right? We just always throw steroids at it, and to help really control the immune system symptoms in ICANS. Now, we're hoping we're going to get some better therapies than steroids, and that's what a lot of people are doing research on right now. And as I said, the vast majority of patients do respond fairly quickly to these therapies, and there doesn't seem to be any long-term side effects of having had CRS or ICANS. So the next question is, somebody's in a remission now, so now what, right? What are the chances of my leukemia or lymphoma coming back? So in lymphoma, there's a fairly good chance that if we're able to get rid of the lymphoma completely, that those patients will go on to have a good long-term cure from their lymphoma, it appears. In ALL, it's a bit more difficult. We get still around 50% of patients to have a good long-term cure, but this is potentially also with the effect of having a transplant after CAR T-cell therapy. So maybe that this therapy is not replacing a transplant, but is enabling those patients who have such refractory disease that they're not able to get to a transplant to get them to that transplant. Our hope for the future is that we might be able to get away from a transplant entirely in some patients and all those side effects that go along with a transplant. So a lot of the research I'm doing is in the fact that, I do see that, again, these are patients, these are people, right? And so we're not done, as was said, right? Until we can get this curve, flat across, we're not done in terms of what we're doing. So we're trying to figure out a way, why, first of all, are these patients not responding to the therapy? And in terms of why is this thing that we've made not working for them, right? And what can we do to make it work better for them? And so that's really what we're really concerned about right now, and some of the research we're doing. So what about other cancers? As I said, it works very well for B-cell cancers. So some other ones that there's been some more work in is like chronic lymphocytic leukemia. And this is typically in patients who have gone through multiple lines of multiple therapies. So not the typical patient who's only received 1 or 2 lines of therapies. This is usually in patients who have received 10 different types of therapies already. And it seemed that 74% of patients did respond in one study at least, but it does seem to work better if it's combined with another drug. So this is in the setting of if it's combined with a drug called ibrutinib, it seems to work better in that setting. So I think we need to really do a lot more research still in terms of how can we make this work better in CLL. In follicular lymphoma, it seems to work well as well in these patients who, again, have gone through multiple other therapies. But more research is really needed before we can really say confidently outside of a clinical trial that these are really good therapies for patients. And there's also a lot of research ongoing in terms of myeloma and looking at other ways of targeting different cancers. So myeloid leukemia is also something that's being looked at, but one of the big difficulties there is the fact that if you target really a lot of the myeloid cells, it also is your normal blood cells, and so it really could wipe out your normal blood system. So there's a lot of research going on throughout the world about how to improve those. So my lab in particular is looking at making some myeloma targeted ones, as well as doing some research on a clinical trial that we're going to be starting here relatively soon here in BC, that's actually open right now in Ottawa, in terms of trying to see if we can understand from some patient samples, first of all, why are patients not really responding initially after CAR T-cell therapy, so we can make better therapies. So in conclusion, basically they've demonstrated success in these refractory B-cell cancers. These toxicities are common side effects, but they are reversible in the majority of cases with appropriate therapy, and we're working on making better therapies for patients. Relapses do occur in the first year after therapy, and more research is needed there. So that's what I was mentioning I'm really focusing on. And also there's active research ongoing in CAR T-cell therapy in my lab and in other labs, actually here in BC, but also throughout the world. So thank you very much.